Thank you very much. I'm going to spend just a little bit of time today talking about some of the areas where I think troponin can be terribly helpful, in particularly as we move toward high sensitivity troponins, and then a little bit of information about chest pain and rule in and rule out. I'm going to leave the details of how to define a changing pattern to Dr. Labani, who's going to talk about that. Let's see, how do I make this move? Okay. One of the important issues to keep in mind, there's been a lot of confusion, is we really don't 100% know how to define what high sensitivity assays are. So this was suggested as probably the only way we have to think about it, which are the number of samples of normals, of putative normals, that are detected by any given assay. And Fred Apple suggested 50% should define a high sensitivity assay. The reason this is important is that if you start sending out samples, everybody wants to be a high sensitivity assay. Well, these are the samples that he sent out, a couple of hundred samples. He sent them to the companies, had them measure them. What you can see is that most of the contemporary assays don't detect very many. Some detect a decent amount. Note that what was thought to be a high sensitivity assay, at least in this analysis, didn't detect very many normals, suggesting that maybe these assays out here are more sensitive. And the only reason to talk about this at all is that there's been tremendous confusion because everybody wants to call themselves a high sensitivity assay, and it confuses clinicians about which is which. If you have high sensitivity assays, as with anything else, there are going to be lots of elevations of troponin. This is just a list. You don't have to look at it very much. I develop it, I change it every day when I add things. And all of these things have a very reasonable pathophysiology. But let me show you some of the reason why many of us are excited about high sensitivity troponins. First of all, in terms of just epidemiology in the community, if you take a look using, in this instance, this troponin T assay, with previous assays, less than 1% of people in the community, recognizing that there are people in the community who have heart disease, had elevated values. You start using higher sensitivity assays, and again, as I showed you, given this assay is not yet as sensitive, it's about 2%. And if it's 2% in the community, since the patients who have cardiovascular comorbidities often are those who present with chest pain, maybe it's 10 or 15% in the emergency room, maybe it's going to be 10 or 20% on the cardiology services. But there's some very nice help that this will give you. These are data from a trial called Heart and Soul. It's a group of patients with putatively stable coronary artery disease that are evaluated utilizing high sensitivity troponin T, if that assay is still high sensitivity. And what you can see is that individuals who have elevated values are a particularly high-risk subset of patients who have chronic stable disease. I put these slides in for Judy, really. If you look at this study published in ATBB, there is a graded relationship between the value of troponin and the extent of coronary disease. And note, as we'll talk about later, as with all high sensitivity assays, women have lower values than men. If you look at the determinants of those elevations, and this dovetails nicely with the talks we had this morning, the ones with elevations tend to have remodeled plaques, less calcified plaques. Now you could argue, and nobody knows the answer just yet, that these are the plaques that we were showed this morning that have persisted. You could also argue that this group shown here with the elevations do so poorly because these really are acute plaques. and that rather than this being a chronic elevation, it's an acute elevation, and those data are not in yet. Nonetheless, if one starts to look at the data about triaging patients utilizing troponin, high sensitivity, here's the PEACE trial looking at high sensitivity troponin T. You can see that within the quartiles of high sensitivity, there's a gradation of risk. Also note that only 11% of the patients in this trial had a formal elevation in this fourth quartile. So within what we call the normal range, quote unquote, there still is prognostic significance, and there are two probable reasons for that that are easy. One is we haven't measured the normal range very well, and that's true. As we start using MR and more sophisticated tools, these normal, what we think is normal in the 99th percentile will come down. And secondly, some people will have disease and have events. They'll start from a very low number because they'll be reasonably healthy to start, and there's some variability there. These are the same patients now with the quote unquote high sensitivity troponin T accounted for, showing you that when you use still a more high sensitivity assay as defined by Fred Apple, which is the Abbott assay, that you get still a greater separation of these patients. And interestingly, a large percentage of this difference is ischemic heart disease, whereas most of the events in this analysis of PEACE have been death or heart failure. It's interesting that the higher sensitivity assay began to unmask ischemic heart disease. Similar data can be shown from HOPE. This utilizes a high sensitivity Beckman assay, again, splaying out for a variety of outcomes. Now, the key question is, what should we do about it? And nobody really knows yet. And so we're not here advocating, I'm not here advocating that we go and start measuring this on everybody with stable disease. I am suggesting that we need to do studies to figure out what we do with that subgroup. Maybe it's the group that crossed over in courage, Judy, and we should define it pre-hoc. Here's one indication which I think may play out much more acutely and we might be ready to use. These are data that come from RELY, and it uses the Beckman assay that was tweaked to make it more sensitive, showing a relationship between death, vascular death, and troponin I. And that's not surprising. You've got a cohort of people with cardiovascular disease. The higher the troponin, worse off they are. But these data are a little more provocative. That is to say, not only was there prediction of cardiovascular death, but there was prediction of systemic embolization. And as a matter of fact, you plot this against the CHADS-2 score, there's tremendous augmentation of the CHADS-2 score. I won't show you the slide of the CHADS-2 VAS score, but I promise you it works just as well. And there's coming data from Aristotle as well, augmenting this a great deal. And I think this is the one area where I don't think we're probably going to be willing to wait for therapeutic trials. I think we're probably going to be willing to start anticoagulating people who have higher values once we define those index values for each of the assays. Heart failure with high sensitivity is going to be a huge confounder when it comes to the diagnosis of MI, because everybody with heart failure is going to have an elevated high sensitivity troponin. The pattern is what's going to be important. And people who have larger areas under the curve and who have increasing patterns seem to do worse. Almost looks like infarct size way back before we started to intervene. And you can play with this and add BNP and get additional prognostic significance. This also has value in the chronic heart failure patient. These are deciles of troponin T at baseline. And not surprisingly, there are data from clinical trials suggesting that if your troponin stays stable, you do better than if it decreases or increases. And we've shown, and others have as well, that a changing pattern of troponin over time identifies patients at higher risk, so that there is tremendous potential for this to be used to guide therapy. And this is being looked at in the large trial that's starting in the United States utilizing NT-proBNP as well. One of the ways that high sensitivity has to go to make its way is to start to define therapy that we can use. It's not good enough to say there's increased risk, all right, because saying someone has a risk of twofold instead of threefold or fourfold doesn't really tell you what to do. But there's starting to be therapeutic trials, and there's starting to be techniques that may be helpful. And this is a trial that came from Japan, utilizing patients who had cardiomyopathic heart failure, in whom they assiduously ruled out coronary endothelial dysfunction. And they asked the question, what does the troponin relate to? It relates to LV-EDP, pulmonary capillary occlusive pressure. Almost makes you think that we ought to go back and reevaluate Lynn Warner Stevenson's suggestion that we really need to substantially diurese patients down to very low filling pressures. She showed years ago that you do not lose cardiac output or stroke volume doing this, but now we have a technique, we have a tool now that would allow this strategy to be reevaluated. One last example, and that's in the community. If you look in the community cohort, this is from Jim DeLamos's Reynolds cohort, you can see again, no surprise, these simply identify patients who are at cardiovascular risk. You look at an older cohort, the prediction of heart failure occurs, and with that, not surprisingly, if you have an interim value, if it's going up, you're worse off. So there are tremendous number of things that can be done. We've recently looked at a community cohort, and we think that with the combination of high sensitivity troponin and NT-proBNP, we could develop a trial with about 600 patients in each group to see if one could affect the development and the movement from stage A heart failure to overt heart failure. This is another area that's going to emerge. This comes from Italy, Cardinale's work. You know that if you have an elevated troponin and you're getting cardiotoxic chemotherapy, your ejection fraction tends to go down. If you treat them with ACE inhibitors, the troponin goes away and the reduction in ejection fraction goes away. Many of the drug companies in the United States, almost all of them, are using very high sensitivity troponin to screen their compounds prior to investing big time in them to look for cardiotoxicity. So, all of these wonderful things that we can do, and I could show you many more in valvular heart disease, where I think following high sensitivity troponin will be uniquely beneficial. But what it's going to do is make it a little bit more difficult to define acute myocardial infarctions. And again, I'm not going to talk about the components of a delta change, but these are data from Dave Morrow. What he did was to take 50 patients who had MI, documented in the TIMI trials, and simply showed the shortening of the time it takes because of these higher sensitivity assays. He then looked at 50 patients with putative unstable angina. And what you can see is unstable angina nearly goes away with this assay. As a matter of fact, many of you may know that Dave and Gene Brownwald wrote an editorial in Circulation a couple of weeks ago suggesting that unstable angina was gone and that one should have an elevated troponin and therefore have a non-STEMI. These are data for the Beckman assay. 21 additional patients identified. Are those patients at greater risk? Yes. But there's a lot of hype about how fast this is going to happen that I think is excessive. And the reason I think it's excessive, and I'll use this example, is that the gold standard that's being used is this. And I haven't animated this slide. I usually do. But these assays are the same as these assays. What's the difference? They use the proper cutoff up here. They use the wrong cutoff up here. If you use this cutoff, you make everything look much faster and much better. Here's an analysis we did, and the consequence is you can publish data like this that says it's all over in 1 or 2 hours. If you take a look at this in a cohort that we looked at called TUSCA, this is on the American Journal of Medicine website, if you use the 10% CV value, you save 68 minutes from the 4 hours that you would ordinarily take to make the diagnosis. You save 11 minutes if you use the 99th percentile. But if you use the high sensitivity assay, you add an hour because the new MIs that you detect take longer. So I think there's excessive hype in this area. I'm going to leave this for Dr. Plabani. There's going to be nonetheless good strategies to diagnose and distinguish patients who rule out at a very early point in time. We know that it'll be the delta that's important in making the differences, and we, as an organization, the Global Task Force, as well as several other organizations, have suggested that labs should make this distinction and report it. We've been doing that for the past 5 years at the Mayo Clinic. Now, this is an area we touched on this morning, differentiation between type 1 and type 2 MI, and this is changing as well, because the reality is that type 2s seem to have lower troponin values, so you're going to have a different distribution of type 1s versus type 2s as you get more sensitive. And the importance of that is that with the higher assay values, the type 1s all were shown in a variety of studies to benefit from an aggressive interventional approach. That may not be true as we get to these higher values. And here's some data just out in the American Journal of Medicine. And one of the issues we talked about this morning is we don't know quite how to define type 2, but we sat down with a group from Denmark and said, if we had to guess, here's what we guess. And what you can see is that if you guess type 2s and type 1s, you can see that nearly 50% of the type 2s did not have significant coronary artery disease. All right, now, in addition, when you had coronary artery disease, you tended to have fairly significant high-grade coronary artery disease, less single vessel disease, more double vessel disease. So these are different patients. I would argue, although the analysis is not done yet, that this may fit very nicely with the differences that we talked about this morning. If one looks at high sensitivity troponin, men have higher values than do women. I'm a very strong advocate. I think we've disadvantaged women in the diagnosis of cardiovascular disease for a variety of reasons for a long time. And I'm a big advocate for thinking that we ought to use different gender-specific cutoffs. And women, because they have different pathophysiologies, are very likely to be the ones who have more type 2s, more open arteries as well. I stole this one from Judy Hockman and Harmony Reynolds. Several of us had done studies looking at MR, showing that there are MIs mostly in women, where you detect MIs, and whether or not this is a type 1 or a type 2 becomes even more complicated, because you'd call it a type 2 based on the angiogram and maybe on a positive MR. But if you look, maybe these are all old and not acute, huh? You can see that there's some plaque rupture events here suggesting that maybe they are type 1s. So this is a complicated and important area, but it's very likely, I would argue, that we're going to have to do something different for men versus women. And here is an analysis done of that by Nick Mills, presented at ESC, where he used a different cutoff utilizing the high sensitivity Abbott assay, using a single cutoff with the old assay, or with high sensitivity assay. You can see there are a lot more men who are detected. Utilizing gender specific cutoffs, they become more equal. I won't show you all the slides, but these are not diagnoses that shouldn't be made. These are women that are at risk in terms of their eventual prognosis. So I think this is going to get a little more complicated with the need for gender-specific cutoffs and perhaps even for gender-specific deltas, but I'll let Dr. Plabani handle this. I'll close by indicating that you guys are the ones who have to make the diagnosis, not the markers. And always remember that. The bad clinician is going to get the diagnosis wrong. So this is an interesting era. Welcome to it. Be good clinicians.